Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the brightest and best practitioners for care. To that end, we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these valuable expert resources. Thank you for joining us and enjoy the presentation.
I want to introduce our speaker. Dr. Craig Rundbaken is a pulmonologist with an appointment at Nimbus Health in Sun City West, Arizona. He has practiced in the West Valley, primarily in Sun City West, since 1997. Over the course of his career, Dr. Rundbaken has treated thousands of patients with valley fever, including some of the most complex cases in which the infection spread beyond the lungs, to the bones, and to the brain. In 2014, he authored Valley Fever, Silent Epidemic, a book dedicated to raising awareness about this often overlooked disease. He has delivered numerous lectures throughout the years, especially during Valley Fever Awareness Month, helping educate both physicians and the community. Before joining Nimbus Health, Dr. Rundbaken was in private practice from 2003 to 2023. During that time, he founded the Valley Fever Clinic alongside his pulmonary practice, recognizing the growing demand for specialized care as both the population and incidence of valley fever increased in Arizona. Dr. Rundbaken lives in Scottsdale with his wife, Laura, and they have one daughter, Ariel. Outside of his medicine, he enjoys jogging, skiing, and the pursuit of mastering classical guitar. Ladies and gentlemen, Dr. Rundbaken.
Thank you. Well, my teacher would say mastering. He's very frustrated with me, so. But it's fun and I enjoy it. It's good for my brain. I moved here originally from Farmington Hills, Michigan area, and we don't have valley fever there. So when I moved here in 1997, I started seeing a lot of pneumonias, and I was pretty shocked how many of those cases turned out to be valley fever pneumonia. Some of the lung tumors looked like lung cancer, turned out to be valley fever. So it was a big eye opener, and then it seemed like every day I'd see cases coming in with valley fever. So I definitely took an interest in this disease. I found it to be very fascinating, very interesting history of valley fever, and the people engaged in valley fever are quite interesting people. So again, the goal of this lecture is to help raise awareness of valley fever. Just to give you a flavor of the severity, the latest statistics from the health department in 2023, there was about 10,990 reported cases. So if somebody has a positive blood test in Arizona, that's counted as a case. So we'll talk more about that later. 93% of the cases occurred in Maricopa, Pima, and Pinal. Ground zero for the world is Maricopa County. The highest case rates are in the 75 to 84-year-old age group. There was 805 hospitalizations, translating to $73.9 million and 74 deaths. And if you add outpatient expenses and ER visits and missed work, it's huge, the dollars associated with valley fever. I've always thought the deaths have been a little bit underreported. Often on a death certificate, a patient will have a diagnosis of community-acquired pneumonia. A lot of those are probably valley fever. Hard to know for sure. So every year, the state of Arizona has a Valley Fever Awareness Week. This year it's November 10th week. And so they always have a proclamation here. And it just states that Valley Fever is a hub of academic activity for Valley Fever treatment, that we get the most cases. And so it's just a week where you might see some more media, lectures at the medical schools and that sort of thing. But it's just trying to raise awareness of the severity of the disease. So this goal is to help, again, raise awareness of the signs, symptoms, and diagnosis of valley fever, treatment pitfalls, some of the differential diagnosis, what other things can cause that can look like valley fever. And the key, of course, is trying to make the diagnosis. It can be a little tricky. It's often delayed or totally missed, especially if you don't live in Arizona. So over the years, valley fever has gone by different terms. Health professionals, we typically just call it cocci. The fungus is coccidiomycosis. But desert fever, which just fever associated with pneumonia, it was originally identified in the San Joaquin Valley in California. So the San Joaquin Valley fever is a name. Later it was identified around 1935 in Arizona. Desert rheumatism, due to the arthritis pain, rash you can get with valley fever. Interesting history with Wernicke-Posadas disease. And that goes back to the original case. I'll show you an interesting picture, attention getter in just a minute. But Robert Wernicke had a lab in Buenos Aires, and one of his students, Alonso Posadas, was there as well. And an Argentinian soldier showed up in their hospital, and they helped take care of him. His name was Domingo Escura, and that was around 1891. And they were trying to figure out what this soldier had. He had all these lesions on his face, and he was sick, waxing and waning fevers, enlarged lymph nodes, rash. So they tried for several years to try to treat him, and he eventually succumbed to the illness. But they were credited as treating the first, what would be known as valley fever case. And interesting, the 1940s, in 1940s, they found, in the 1940s, a physician at the hospital in Buenos Aires was going through the museum there, and he saw this, and he thought it looked like what Dr. Robert Wernicke was working with that gentleman. So he did some pathology slides on Domingo Escura. It turned out to be the valley fever, and so that's the first only original case. Somehow it was preserved. I always remember my high school speech teacher said, you need an attention getter when you start your lecture. So that'll do it, right? So valley fever is a dimorphic fungus, meaning that there's two phases, how it lives in the soil and how it lives in animals and humans. In the soil, it's like a mold. They call that a saprophyte. In humans, it has more of a parasitic phase. It's usually on the surface to about 6 inches below the surface. The medical name is coccidiomycosis. There's 5 major classes of fungus, and this is Ascomycetes class. 2 species have been identified. Immitis was the original one seen in California. And later, in around 2002, a new species was identified named after Posadas. So they're treated the same. They look very similar. But Arizona gets more of the Posadas species. The spore is extremely small. You can't see it. It's 3 to 5 microns. So put about 14 trillion a square inch. It only takes 1 to cause an infection. So once you inhale it, it will show you slides that it changes shape and grows. So think of like a micron. There's about 1,000 microns in a millimeter, 1 million microns in a meter. So extremely small. So on the right side is the saprophytic top. You see the mycelium. That's kind of like a mold in the soil. There's alternating barrel-shaped spores here. And there's like a cartilaginous, what they call disjunctor tissue between the spores, and it's very easy for those to break apart. They can take flight. With our dust storms, they can travel to other states. So as they get kicked up, whether it's construction, dust storms, hobbies, golfing, ATVing, they take flight, and then any animal or human that inhales it could potentially get sick from it. So once it's inhaled, it starts to change shape. It becomes a sphere and it grows. It grows to about 75 microns. Inside the sphere, it almost looks like a grapefruit. There's internal septations. And inside the sphere, more spores are being produced. And the sphere tends to just kind of keeps growing and growing, almost like a water balloon getting bigger and bigger. And then eventually it can rupture again right into the adjacent tissue in your lung. And then that can spread potentially to any organ in the body via the blood circulation or lymphatic system. So here's a closer slide of that disjunctor cell, and this is how it is in the soil. Really nice slide of the barrel-shaped spore. So here you can see the spherule with endospores in it, biphasic cell wall, which makes it very difficult to kill, which makes it very difficult to make a vaccine for. It's a very strong glucose polysaccharide type substance they call chitin. And so there's been a lot of work. All the antifungals we use don't kill this. It just kind of helps neutralize and prevent replication of that cell wall. You can see a spherule in the meninges here of the brain up there. And again, there's some in this in the brain here. Now, I know this can be alarming. And how often does this happen? It's thought that we call this dissemination, less than 0.5% of cases. So if somebody's more immune suppressed, that would be a higher risk for dissemination. There's other things that we'll go over later. So how do you get valley fever? The only way you can get valley fever is if you inhale the spore. So if your spouse has it, it's not contagious person to person. If your dog has it, you're not going to get it from your dog. There's been very rare cases of like a cat scratch bite causing a transmission, or maybe an open abscess type thing where somebody came in contact with that, but those are extremely rare, very rarely reported. Rare cases of maternal fetal transmission. Dogs get it here quite a bit. Some of you may have had your dogs get valley fever. They get treated basically with the same drug. Spores blowing out in the ocean, and zoo animals are common as well. We talked about direct contact. So again, it's not contagious, just you inhale the spore, you get sick, it goes to the lung, causes a fungal pneumonia. Valley fever is a fungus. So when you go to the ER and get your antibiotic, it's not going to work. And you go home, we'll talk more about that. So incubation's thought to be somewhere up to 28 days. The symptoms of valley fever overlap quite a bit with flu, COVID, fever, chills, night sweats, cough, pleuritic chest pain, headache, weight loss. If it's a bad pneumonia, you can get coughing up with blood, which is hemoptysis. The most profound symptom I noticed over the years, and it's pretty well reported the same, is fatigue. People that get it, they're just wiped out, their energy's low. It seems like the last thing to recover, typically around the 6-month mark. So some of the clues that we're dealing with valley fever, one is that profound fatigue. It seems a little bit more common with valley fever than you'll see with other pneumonias. And we also can get a rash about a third of the time. Erythema nodosum, erythema multiforme are the two big ones. Toxic erythema is more just due to the fever. Some people lose weight, they don't want to eat. Arthritis, pain, joint pain, and then conjunctivitis. So there's some clues that help professionals make the diagnosis. So toxic erythema, it's a fine red rash. It kind of looks like this. And again, you can see this with other fevers. It's not solely with valley fever. This is a very common one. This is erythema nodosum. You get these welt-like lesions on the shin. And it can be on the extensor surfaces of the forearms. They're painful. They typically go away 2 to 4 weeks, but that discoloration can last several months. Usually what we call self-limited, you don't have to treat it, but if it does cause pain, we generally use anti-inflammatory medications, like Motrin or those sort of things. You can get swelling in the feet and ankles with this as well. So it's basically, the way I like to think of it is an allergic reaction to the fungal spore, which is the antigen in your lung. So it's actually thought to be a good sign. You're making antibodies to the antigen, which we want to do, and that's what's creating the rash. So you get these inflamed subcutaneous fat cells, and we talked about this. I try to avoid treatment. I try to avoid steroids with valley fever. Valley fever tends to thrive in a high steroid, high sugar environment. Yeah, this is a real bad case. So erythema multiforme is similar. It's you develop a rash. You get these. It's different mechanism. Immune complex deposits. You get these often red target lesions. Can be itchy. Can be up here. Basically, I've seen it anywhere in the upper body, abdomen, back, even legs and thighs, and that gets missed quite a bit. And often, again, it's thought to be an allergic reaction to an antibiotic somebody's had multiple times before and never had a problem with. But around here, if you have a pneumonia and a rash, it's probably valley fever. So you can see this with other diseases. It's not just with valley fever. Erythema nodosum and erythema multiforme are seen with other illnesses, drug reactions, lymphoma. So yeah, this is a gentleman that was in my practice. He lived up in Washington, and he kept telling the doctors. He told me to check for valley fever, but they didn't. And then he came back, and his antibodies were positive, and he had this classic target-like red lesions of erythema multiforme. Put him on antifungals, and he did great. So this is interesting. So a dermatologist referred to me because he knows I like valley fever, and this gentleman had a severe necrotic lesion on the apex of the nose. I put him on a high-dose fluconazole. About a year later, he looked perfectly normal. Didn't need surgery, just kind of healed well, believe it or not. Those tend to do really well. Again, these are not common. But this is what I see probably weekly in my practice, these sort of things. This gentleman has rheumatoid arthritis. He is on Remicade or similar biologics, and this lesion wouldn't go away on his lip, and they biopsied it. It was coccidioides spherules in the lip, so that circular sphere you saw earlier under the microscope was there. This poor lady had meningitis and a lesion on her finger. Fortunately, she's from Minneapolis, Minnesota area. Went back to see what they did, and then so she was on treatment for meningitis. Why do we get it more often here in Arizona? Again, Arizona, we have the most cases in the world. Maricopa County has the most cases in the world. We're starting to see it in other areas as well. They found some in the Walla Walla area in Washington. They think due to global warming, it's starting to be spread elsewhere. But it's dry alkaline soil, hot summers, warm winters, low altitude, minimal rainfall. In Arizona, we tend to see it more June, July, then usually post-monsoon season up through January. And that's due to our monsoon season. I mean, we've had so many haboops lately, all that dust, and creates these sort of bimodal seasonal variants, whereas in California, it's usually just June through November where they have a higher case rate. So Maricopa is greater than Pima, greater than Pinal County. So you can see the hot spots here in yellow. Kern County, Bakersfield area in California, Maricopa County, Pima, Pinal, but it's in parts of southwest New Mexico, southern Nevada, parts of Mexico, Chihuahua, Mexico's that area. But again, you see those stars over there. So we've seen cases in Washington. The one in Colorado there, that was a dinosaur national monument. Around 2000, there was an archaeological dig, and all 10 workers got sick. So it's an area and a climate that's not usually associated with valley fever, but the soil there was had a tremendous amount of spores. So basically, back in the 40s and 50s, there was a widely available skin test. There's a newer one also available, but the skin test told if you ever had valley fever. Some scientists went around doing epidemiologic studies, and they basically came to the conclusion that about 3% of the population per year comes in contact with the valley fever spore. They turn positive, and of those 3%, about 40% become symptomatic. So I always thought that was a very good model to try to predict case rates, right? If you use that model with population growth. There's always some debate about the quality of the skin test, what was in the skin test, could that have created a reaction? But that's kind of the model that's still used. This study really hasn't been repeated. And again, a very small percentage will disseminate. So I know we've had a few of these lately. Interesting, I came across a study that looked at over like a decade, and they actually didn't see quite a huge increase after haboobs. But with that said, I'd be careful, stay inside. So in 1994, after the Ventura County earthquake, there was quite a uptick in cases. And so any of these things, of course, make common sense if you're outside. Any plume of dust, and you're around that. So once I started learning about valley fever, when I came here, I'd mask up if I'm sweeping the garage or working in the yard. And then I got valley fever, so I stopped doing that because you typically don't get it again. But PGA golfer Gary Kraft and Connor Jackson had it, baseball player. So I want to go over some just medical stuff here, some X-rays that are common. What do we see that can help us also differentiate from other pneumonias? So valley fevers common in the upper lobes. So it's interesting. Like with smokers, we always say emphysema is worse in the upper lobes, and smoke goes up. Maybe the spore is so small that it hits it goes. You breathe it in, and it just migrates to that area. But you can see this is part of the right upper lobe here, and that's called the right upper lobe consolidation. There's also some infiltrates way up high and lower down. This is the hard shadow. So that's pretty impressive pneumonia. And then you can see it healing up a few months later. People begin to feel much better before their x-rays clear up, typically. Yeah, here's another right upper lobe. Again, that whole middle area is the heart shadow. The heart kind of looks like a big glass of milk on a chest x-ray, And so this is always more concerning to me. These are cavities we get with valley fever. That's a left upper lobe cavity, and you can see a big kind of consolidation right there, or a white area. That's the pulmonary artery. So the edges of the cavity tend to be, I describe kind of the layman like muddy. They're very necrotic, they're inflamed, and these cavities can expand. So my worry anytime I see a cavity is it close to a blood vessel? Because you start bleeding, you could even have major bleed and die from that. So I'm real careful. Sometimes if they're close to a vessel, a major vessel, refer to thoracic surgery. Even if they're not going to do surgery, they have a relationship, just to be on standby. Because on occasion, they'll end up in the ER coughing up blood. And here's what we call pleural effusion. That's fluid associated with pneumonia. We see this with bacterial, viral, fungal pneumonias. It basically fills up the cavity on the inside, and it has to be drained either with a needle hooked up to what we call a vacuum bottle, called a thoracentesis, or a chest tube that's connected to a chamber that just lets the fluid drain out. Occasionally, those people need surgery. Here's a different view, a cross section of a right upper lobe nodule. As that pneumonia heals up, it starts to form more like a solid nodule, and that solid nodule looks like lung cancer. So a lot of physicians get nervous. They refer because the patient has a mass. If it's close to the time of the valley fever, and they order a PET scan. PET scans light up like a Christmas tree with infection, so valley fever looks like cancer on a PET scan. So I try never to order those because then it creates, a push for biopsy when you may not need it. Part of the way we make the diagnosis, also other than clinical signs and symptoms, is with blood tests. There's Sonora Lab. We do the enzyme immune assay and the immunodiffusion. We see a lot of false positives in the past with the enzyme immune assay. The newer test kits are much better. We try to confirm those with the immunodiffusion test. So if you get a blood test for valley fever at Sonora, you'll probably see both of those if it's ordered. Then we also order what's called complement fixation titers. It looks for the quantity of antibodies in your blood. So the higher the titer, typically the worse the case. It's a ratio. They put your serum in a vial along with a salt solution, and it's so it would be a normal would be negative color change, and 1 to 2, 1 to 4, 1 to 8, 1 to 16. Anything over 1 to 16 where the color change stops would be considered a high titer. So we worry about dissemination to other parts of the body when it's over 1 to 16. And let's see, sometimes we'll see a type of white blood cell called eosinophils elevated a third to a fourth of the time. It's kind of a clue. Unfortunately, that can be misdiagnosed as eosinophilic pneumonia, and they often treat that with steroids, which I don't like with valley fever. So again, it's really good to think these through. Sed rate and C-reactive protein, or markers of inflammation, are usually elevated. Especially if somebody has joint involvement, we track those along with the antibodies to see if they're coming down along with treatment. Some of you may have heard on the news there's a test going to be out this year, which we're all waiting for, but this test likely got delayed because it's not available, but there's a rapid antibody test that Mayo and ASU are collaborated on. It's just a little blood test, finger pick, and to see if you have antibodies to valley fever. So hopefully that'll be out. That'll be a game changer for ERs. Historically, ER doctors, urgent care doctors, don't order valley fever tests, which is a real problem. Part of the reason is that by the time the test comes back, they're not there. But we need people to look at those. Again, it's thought to up to a third of all pneumonias in the valley are valley fever, so we're missing a lot. So you can prompt your doctors to order the valley fever test if you get pneumonia, or your friends or your family once they leave here and go home, and to order the coccidiomycosis blood test. So certainly some doctors aren't familiar with the test, but we call it cocci. So it's cocci antibodies is the name of the blood test. And so valley fever, again, has been reported to the valley fever since about early 1990s. I believe it was 1994 when it started. The unfortunate thing is if you have a positive test, you have valley fever. So again, if there's a false positive, you're still going to be counted. Some of these statistics, I think we showed you, there's 10,000, this is back from 2023, I think I went over these with you, but this is kind of better. You can't really see this, I try to make it more clear, but back in 2009 through 11, case rates were soaring then. And 2023 there was 10,990, and then 2022 9,515. So again, a lot of people get it and it's never reported because the diagnosis gets missed. People get better on their own. So before there was any treatment, most people would get better eventually. So high-risk groups, males are a little bit higher risk, thought mostly due to occupational related. We showed you the older folks due to the immune system weakening. Same with infants, weaker immune system. Organ transplants are at higher risk. Pregnancy is a high risk also. The hormones of pregnancy create an environment where the spherules can really grow. Anybody with decreased, what we call cell-mediated immunity, you need good cell-mediated immunity to fight valley fever. So HIV, and then there's certain ethnic groups that have some genetic markers that have more difficulty fighting the valley fever fungus. Okay, so drugs we use are antifungals. These are the big ones. The most common is fluconazole. They tend to cause dry skin, dry lips, constipation, alopecia, which is hair loss. Often I'll use itraconazole, especially in women, because I'll get the phone call a few weeks later that they're losing their hair. So it's a little bit better on the hair, but it's not as cleanly absorbed. Voriconazole is also good. We use that for more patients that are feeling fluconazole or itraconazole. Can cause visual changes, and if you're out in the sun, it can cause a bad rash. So you got to really protect your skin. Posaconazole is also a very good drug for valley fever. So posaconazole, voriconazole, itraconazole were all made for aspergillosis, not valley fever. None of those drugs were made for valley fever. There's another drug that's newer, Cresemba, again, not made for valley fever. Some people are using. Basically, it disrupts the cell wall and prevents replication, hopefully improves healing quicker. And then the first drug available in the 1970s was ketoconazole. We no longer use it due to liver issues and liver toxicity. All these drugs, we monitor liver enzymes usually every 1 to 2 months with valley fever antibodies. And for more severe cases or during pregnancy, you can use IV amphotericin. It tends to affect the kidneys, can cause electrolyte imbalances, renal failure. So I've used this early on in my career. I would treat a few pregnancy patients, and we put a PICC line in, and then we'd give them amphotericin. But most of the time I refer those to neonatal specialists. Of course, I don't want to deal with that anymore. It's just very risky, and so it's always good to have a group of people dealing with valley fever in pregnancy. This drug has been talked about a lot. It's not available. They were hoping to do more studies because they thought it was fungicidal, kill the fungus, but it's just not available, has not been remanufactured. The company that originally developed it went bankrupt, and it was never really brought back to life. And so we talked about these side effects, hepatitis sometimes. You gotta be really careful if people are on statins that try to stop Lipitor, those sort of medications, or warfarin's a big drug interactor. So we always do a drug interaction screen when we start antifungals, because some of the drug levels can go sky high. For instance, if I have somebody on warfarin, I have to typically drop that dose at least 75–80% while they're on fluconazole. And there's a Infectious Disease Society created some guidelines in 2016. So those are available to health professionals. And so how do we make the diagnosis? For me, the best is the clinical history. Do they have fever, chills, night sweats? Is there a rash? Do they have eosinophils in their white blood cells? Do they feel tired? Are they coughing? Is the blood test positive? Great, helpful. If it's negative, still could have it. We see a lot of false negatives. Do they have pneumonia? Is it in the upper lobes? More likely valley fever. So those are the keys. It's once you see a lot, you kind of get a feel, and it's a lot easier to make the diagnosis. The problem is a lot of people don't even think about it, don't even test for it. So I can't tell you how many times, and don't want to be critical of my colleagues, NPAs and NPs and docs, that they get one antibiotic, they get Z-Pak, then they get the Levaquin, then they get something else, and eventually somebody orders valley fever tests or thinks about valley fever. So we've got to be better about thinking about it, prompting our doctors, prompting our friends. It's real risky when people fly into Arizona and leave. Like I said, the gentleman from Washington, or somebody goes to the East Coast, or somebody goes back home to China, everything usually gets a little bit delayed. So treatment pitfalls, when somebody has valley fever and you're treating it for something else, one of the other things I've seen over the years is two problems at the same time. So I'm treating somebody with positive blood tests, treating for valley fever. The pneumonia is improved, but that nodule that's residual, we call it granuloma, is getting bigger. So we biopsy it. And one gentleman had valley fever and lung cancer in the same biopsy. So I always on my toes. I'm always looking for two things at the same time, because somebody that's immune suppressed or has other health issues is more likely to get valley fever. Again, the rash is a big clue, so we've got to be thinking about valley fever. It certainly could be a drug reaction, but if somebody's got erythema multiforme, erythema nodosum, got to think about valley fever out here. And yeah, we try to tell patients if they come in and they're young, if they have valley fever, please don't get pregnant. And valley fever meningitis, we diagnose that by checking the cerebral spinal fluid. And, so that's a lumbar tap where we drain the fluid out of the out of the lumbar area of the back, and we send it for antibodies for valley fever. If that's positive, current treatment is lifelong antifungals. If you stop the antifungals, the meningitis comes back. So it's, I've had people from like 20 years ago, I still see them once a year. They come in. So yeah, it's just some misconceptions. I get this a lot. Oh, I lived here all my life. I've had it, and I've seen people who've lived here 40 years get valley fever. You're more likely, just based on those skin testing findings, 3% of the population per year thing. So with that, you're more likely to come in contact with the spore. You may not be one of those people that got sick with it. So the longer you're here, the more protected you are, but you can still get it. If you get valley fever, there is immune protection, so you don't get it again. It's really hard to prevent because it's so small. I mean, we could put an N95 mask on, but if you do this, or it can still get through. But again, just if somebody's got bad diabetes or lymphoma and you like to garden, it's a good idea. I'd put a mask on. I wouldn't recommend walking around town with a mask. I've had people ask me, but I think you got to look at quality of life, So planting grass, paving roads, avoid the storms. Be careful around construction sites. So that's the slide deck. I'd be glad to entertain any questions. Yes. So anyway, do this.
So is this on? It is not there. Yeah. So do the typical car filters and filters in your house, are they good enough to filter that out?
So yeah, it's a 3 to 5 micron spore. You need at least an N95 type filter. A lot of the home filters can. I'm not up on the car filters. So yeah. We're basically right across the street with Nimbus Health. Yeah.
My question pertains to the yard people that come and work around here. They just love to raise dust. I mean, it's lying all over the place, and it's usually at the time when you want to take a walk.
Yeah.
So how much of a risk is that?
Yeah, that's That's a huge risk, and that really bothers me as well. You can see these guys doing the blowers, and it could be right by here, it could be by a children's center, and it does create a huge plume of dust. They don't seem to care where they point it. Back years ago, coccidiomycosis was considered was on the list of agents that could be considered a biological weapon. So that's part of the reason why it was difficult to do research with it, because of all the rules and regs. So eventually it came off the list. But yeah, really, I would be happy to get rid of those. So it's a risk for sure, yeah.
Quick question. You alluded to the fact that you had caught valley fever at one time. How many times can you get valley fever?
Great question. So, yeah, for me, just since you brought me up, I just, like a lot of people, I'll do an X-ray every couple of years. So I went to do an X-ray and I had a nodule on my lung. I'm like, oh gosh, So like everybody, I got cancer. So asymptomatic. So repeat the X-ray 6 months later or 3 months later, it's gone. And I used to carry the new skin test in my office. But people didn't want to do it because it's over $100 a skin test, and insurance doesn't typically cover the cost. So I did the skin test on myself when it first came out, and then I did it when I saw the nodule, and it was very positive. So that to me it's most likely valley fever. A positive skin test means you've had it sometime in the past. But yeah, there is, people don't get second cases. I don't see that. There is a small risk of reactivation. And kind of the number I throw out to people, I've been here since '97, I've seen about 25 reactivations. Reactivations I've seen in people going on biologics, chemotherapy, kind of severe depression, like spouse dies or moving into a care center. That's a big life change. Immune system just drops. Those are the scenarios where I've seen reactivation, but it's not common. So there are vaccine projects going on because we know there is protection.
I thought I read somewhere that there was more spores in the air after a rain. Is that true?
No, I think maybe you're alluding to what's called the grow and blow theory. It's pretty cool. So you saw those different case rates over time. It's like in 2011, and so if you look back at the weather patterns, they've linked increased case rates with rain. So what happens is if there's a big drought and then a rain, and the spores germinate in the following year, more case rates. Yeah, so it's called grow and blow theory of valley fever, and it pretty much holds up to be true. So I think that's what you mean. So, and valley fever is a very hardy fungus. So in very severe weather, it still exists, and it has few competitors in the soil. So it's very very effective to people.
I had valley fever about 15 years ago, and as a result I had lung nodules. Do you need to be seen by a pulmonologist every year because of that, or is it not necessary?
So the standard of care of which doctors are supposed to follow are 2 years of surveillance. So even if I know somebody had valley fever, I track it for 2 years. It may be every 6 months, it might be yearly for 2 years. If it's stable, hasn't grown, I just kind of say, hey, you have a tattoo on your lung, it's valley fever, it's common around here, and we call that a coccygranuloma or granuloma due to valley fever. But we have 5 lobes, and I always tell people, well, do they have more than one spot? And so again, you got to be on our toes as doctors. Is this just valley fever, or is there something else there too? Because we got a lot of smokers in the past that had valley fever.
Yes, I wanted to ask, just this year in March, we had tremendous winds that came through, like 70 mile an hour. Were there any increases in reports? Because this year they got us, that wind that came through, we noticed everywhere around the property and some in the house, where it was like a very fine black silt. And what he ended up in the hospital, we both got sick with lung problems.
Yeah, what month was that? We were
March,
March.
mid-March.
I'm not aware of any uptick then, and again, the labs do report this to the health department, and they tabulate it, usually yearly, but sometimes you can even catch it monthly. So I'd be curious to go back, and that's open to the public. So if you go to Arizona Department of Public Health, you'll see like A to Z on the top menu, and you put V in, you'll see all this valley fever stuff, and you can see statistics. It looks pretty. So I always review that, before I come here and update my case rates.
Hi, I was diagnosed with valley fever 2 years ago, and so now I'm going to say graduated out of, first it was 3 months and 6 months a year. But my husband has had symptoms since August. It's not pneumonia, we're being told. We go to the doctor every 2 weeks, and he's coughing a huge amount. His immune system is compromised, and do you think, I'm not knowing him, it would be good for him to go see a pulmonary doctor? Because I had said this to him last week.
I do. So in here, there's a big shortage of pulmonologists and infectious disease specialists. So most states, people go to infectious disease specialists. A lot of the doctors in the community know me and know I like treating valley fever, so I get a lot of cases. In our community here, it's the pulmonologists that mostly do the outpatient, but there's not a lot of outpatient infectious disease docs. The ones that I do really appreciate. Yeah, you should, because I treat people with negative blood tests all the time. So, and sometimes it's worth a month of antifungals if they're not on drugs that interact, just to see if they improve clinically, if they have any suspicion of valley fever.
What's your schedule like?
Yeah. They overbooked me yesterday, so okay.
I have a son who is recovering from fever, and he has extreme pain in his joints. As he recovers, will that dissipate, or is that something he's going to live with forever?
Yeah, so the joint pain is usually in the first few weeks with valley fever. I've had a few that have lingered a few months, but that's more rare. Yeah, that definitely goes away. That's also, I've seen, just to throw out, I've seen like patients get severe joint pain and swelling, and then I had a patient who had a rash at the same time, and then misdiagnosed with lupus and given high dose steroids and immunosuppressants. So you can see what can happen if you're not thinking about it. But if it's just straight joint pain, it's that desert rheumatism you get with valley fever, that does go away.
Thank you.
Yep. I love this disease, so you tell me, shoot, I'm ready.
Maybe I missed it. What's the normal amount of time that you're on treatment for the active?
Yeah, so this is a real individual disease. I guess some people come in the office, they're younger and healthier, they feel pretty good, their titers are not high but positive. Sometimes we won't even treat them and we'll watch them. But the general rule of thumb is, I tell people, it's 3 to 6 months. I do have patients that do have chronic coxy, which is that you stop the drug and the antibodies go back up. Some of their symptoms might go back up, and we put them on medication again. And so I've got a few high-risk patients in practice. I just keep them on low-dose antifungals long-term. But 3 to 6 months for what we call primary pulmonary coccidioidosis. That's how we code it in the hospital. That's the pneumonia with valley fever. Most people get better in 3 to 6 months. Okay. All right, did I get all your questions there? All right. Well, thank you. I love doing this.
Thank you, Dr. Brown. Really appreciate it. And he is extremely busy, and we really do appreciate you being here. Thank you. Before you leave, Dr. Rundbaken has a flyer that we put on the table, and it is for a webinar, and it provides a lot of information. Arizona Telemedicine Program connected with the webinar series. So we have that flyer for you. And I didn't give you an introduction of Sun Health, but we've been here for 60 years. The foundation, we want you to think of us as a resource. We need a lot of doctors and professionals in the work that we do, so we want you to call us if you have any questions. And we support both of these hospitals and Banner Sun Health Research Institute. They have 4 life care communities in the West Valley and Sun Health at Home. So thank you so much. Last thing, there is a questionnaire on your seats, and we want to bring education to you. So if there are topics and things that you are interested in, please jot them down. We do listen, and we'll try and bring these speakers to you. Thank you very much. This is our largest group that we've had, so thank you so much for being here.